Yes, so we are good to go. Good evening, everyone. Today, once again, I am your host, Neeraj Gupta, chairperson of the IAP Allergy and Applied Immunology chapter, back with another episode, another webinar. Very important topic today, which is uh, about the biomarkers for airway inflammation. And today, we have a very important faculty, very important speaker, internationally renowned speaker with us, Dr. Manali Mukherjee. Dr. Manali Mukherjee is currently working as Associate Professor of Medicine at McMaster University, Canada, and she is also Chair for Respiratory Diseases at AstraZeneca. She is also among one of the board of directors at International Eosinophil Society currently, and she is a lucid active researcher with a huge H index of 27 and I-10 index of 45. She has also done a lot of work on the airway biomarkers, including the patent on predictors of treating mepolizumab failure with reslizumab. So without wasting much time, let us welcome Dr. Manali. Dr. Manali, thank you very much for joining us today. And please share your screen. Thank you.
Thank you so much for that very kind introduction, Dr. Dhar. I'm going to share my slide and I just want to make sure that it is working. There you go. And you can see my slide, right?
Yes, this is good. Please start.
Fantastic. Okay, for the next 45 to 50 minutes that's been allotted to me, I will be talking about biomarkers of airway inflammation. And as a disclaimer, I would want to very clearly note that I have worked mostly on adult asthma. So most of my talk and most of my data that I'm going to show you, it's going to be from the perspective of adult asthma. But of course, we'll have that space to know where the gaps might be when it comes to the peds population and where things can be. And of course, this will also give me a learning experience to understand where I can, expand my skills as a translational scientist and immunologist in helping pediatricians endotype their patients and help their patients. So without further ado, I just want to show my disclosures. My full-time employment is with McMaster. I am not associated with AstraZeneca. It is only an endowed chair and it's completely something that I hold at McMaster. AstraZeneca is it's the name of the endowed chair, which is for respiratory diseases. I do have research grants from Sanofi and AstraZeneca, which is paid to the institution, and other research supports from some local companies. And any of the work that I'm talking about, I don't believe I'm in conflict, rather than I think industries usually have conflict with me for the nature of the work that I do and for how I call them out on the right use of biomarkers for the clinical trials. So going ahead, when I'm ever asked to give a talk on biomarkers, and I started thinking, what do my generation goes to AI? So I went to ChatGPT and I asked, what is a biomarker? And this is what ChatGPT came up with: that a biomarker is a measurable indicator of some biological state or condition. And if we go into how we define biomarker in an objective sense, for example, what the FDA or the National Institutes of Health would define it as, it's not a very simple concept. There are a number of factors to be understood in what defines a biomarker and what can be ascertained as a biomarker, and how that biomarker can be used in the clinical context in either understanding a disease, understanding its progression, or its response. So as you have it on the screen, you can have a diagnostic biomarker, as the name suggests, to detect or confirm the presence of a disease and identify individuals who have it. You can have a monitoring biomarker, which is measured to just assess the status of a disease as an effect as an effect of an exposure to a treatment or an environmental agent. So the applications are to titrate the dose if you need to. So that's a monitoring biomarker. A response biomarker would be used to show immediate biological response, whether it has occurred in an individual who has been exposed to, say, your therapeutic agent. So that's a response to therapy, that whether there is clinical benefit of, with the treatment that has been given, and if there is a biomarker that can say that, oh yeah, there is this assesses an immediate an immediate effect of therapeutic, or this is actually improving, or this may not be improving, etc. A predictive biomarker, which will help in identifying individuals who are more likely than similar individuals to experience a favorable or unfavorable effect of a given intervention, and which really helps us to identify responders, and you will see we will be talking about this soon. And prognostic biomarker, which is used to identify likelihood of a clinical event, a recurrence or a progression, for example, an exacerbation, and what might be prognostic of it, and who have the disease medical condition or who might actually get that. So I'm giving an example here, so to assess the likelihood of exacerbations or maybe lung function decline. So keeping that in mind, this is how biomarkers can be used, of like putting all of these in context, how it really falls in a disease timeline. So the risk stratification biomarker, screening biomarker, to really understand whether there is disease, development of disease, and diagnosing a disease, and the diagnostic biomarker and the prognostic biomarker, which comes in there with understanding and diagnosing a disease, and therefore to ascertain what the next treatment decision would be. And for the treatment decision is where you have the predictive biomarker, the monitoring biomarker, and the surveillance biomarker. When it comes to asthma, I mean, this is my assessment that I think we do well, at least in the adult population, we do well from understanding who has the disease, diagnosing the disease, even understanding the severity of the disease, to actually give them an intervention that may help. So in this context, there is serum IgE, blood eosinophils, fractional exhale nitric oxide. We will get into each one of them one by one. But these are the surrogate biomarkers that are used at large for assessing a problem that is necessarily residing in our airways, because it's the site of pathology. But these are used as the surrogate biomarkers, and it's been used well thus far. Where we are really lacking is the predictive biomarker and the response biomarker and the surveillance biomarker, as in to really understand the treatment that we are giving, if it is working, who will it work on, who will respond, who will be a super responder, who will not really respond, and who, unfortunately, we might actually cause harm. So this is where the gap lies, even in adult asthma. I know that the gap is quite stretched when it comes to peds. So if we really try to talk about biomarker landscape in asthma, and we will focus on the TH2 burden today, because that's where most of the therapeutic interventions are, and the current development pipeline and everything. So the direct measures are, of course, the biopsies and the lavage, but these are invasive. At least for adults, this is not usually done. I know sometimes for peds, you have no other option but to do bronchs. There are surrogate biomarkers that are used to understand airway inflammation. Symptom assessment and lung function test, which are, I feel, very far off. Blood tests like the eosinophil counts are mostly used, not because it's the right one. It does give us it's a very good marker for a TH2 burden in the airway, but it lacks in many domains, as we will discuss as we go forward. FENO, which is fractional exhale nitric oxide, which is used as a surrogate biomarker in the last 5 to 6 years, and it's becoming very, very common and accessible for assessing airway inflammation. Not eosinophilic inflammation, and we'll come to that. It's airway inflammation. And then there are a number of things that are in the exploratory domain. But the direct non-invasive method, which has the best association with the gold standard measurement of bronch, is looking at sputum assessment. So the importance of sputum and looking directly into the airway, looking if there is looking at the eosinophils present in the airway, it's not something new. I'm citing a landmark paper from Harry Morrow Brown, 1958. This was published where he treated patients with asthma, but looked at the eosinophils on sputum smears, and he treated them with corticosteroids, and showed a clear indication that if you do that, exacerbations are reduced. So I think that was one of the starting spaces where corticosteroids, inhaled and or oral, became kind of a mainstay cornerstone treatment for treating asthma, essentially because eosinophils are very key in progressing the asthma pathology. So that if we really understand that, okay, then why, like the objective measurement of it, so going from what Dr. Brown did to having an objective understanding that yes, there is a need to do it, is the study that I will cite right back from 2000. I was still in my undergrad at that time. Sorry, I was still doing my A levels, I think, and this is when Dr. Nair, Professor Param Nair, who's my mentor, did this study where they assessed between clinicians making an agreement based on their clinical acumen and then using an objective measure of sputum to assess who has airway inflammation and who does not, and thereby treating the patient. And here you can see that between highly qualified clinicians and looking at an objective measurement, there was no agreement whatsoever. So it was like almost flipping a coin. You could get it once right and once wrong as to, based on symptoms and stuff, whether this patient has airway inflammation or not. So herein lies the importance of objective measurement. And since then, we have been looking at airway inflammation. So before we go into eosinophils, TH2 burden, and looking at more serious parts of it, as an immunologist, I take a lot of joy in showing this little bit of a crash course on the importance of eosinophils. So what I'm showing you here is a classic TH2 pathway. So here you have the epithelium, you have the dendritic cell that will pick up on the allergen and get that signal. As soon as that signal comes, the TH0, the helper T cell, gives out a hemopoietic signal, which is basically IL-3 and GM-CSF with IL-5, that then goes into the bone marrow and allows the CD34 progenitor, eosinophil progenitors, to then become committed to becoming an eosinophil by expressing IL-5 receptors, and then that gets mobilized into the blood. So this is now again IL-5 being crucial to it, and now the chemokine eotaxin comes in, because these immature eosinophils that comes out into the blood starts expressing a chemokine receptor called as CCR3, which is essential for getting the eotaxin to bind to and bring it to the blood. In the blood, you will have the eosinophils circulating, and when there is indication from the tissue, in this case airways, the eosinophil gets recruited into the airway. It crosses the endothelium, comes into the airway, into the lung tissue, into the lumen by again a gradient that is by a chemokine gradient of eotaxin and CCR5. And once it's in the tissue, it gets activated based on what is there in the microenvironment. So a number of things can be there that can lead to the degranulation of the eosinophils that will release all sorts of granule proteins, cytokines, and that degranulation, that activity is what is associated with the clinical symptoms that you see in the clinic. On the other side of things, when the TH2 cell is activated because of an allergen or any of the other epithelium activation, it will also release other T2 cytokines such as the IL-4, IL-13, and the IL-9 that can lead to the B cell IgE, the classic allergic cascade. The IgE will go and cross-link with the mast cells again. It releases histamines and all different sorts of cytokines that can maintain and stabilize a T2 inflammatory microenvironment. And of course, it will also lead to airway smooth muscle dysfunction, which is literally what will cause you, it will cause a smooth muscle dysfunction. The smooth muscle itself will also be a source for maintaining a T2 inflammation, because it can release chemokines like eotaxin and rantis. Now, this entire phenomena is corticosteroid responsive. So essentially, if you give them corticosteroids, inhaled corticosteroid, this should be, you should be able to maintain this. The eosinophils should come down. The IgE dependent mast cell degranulation and the downstream effect of the mediators that cause all the symptoms should be able to be managed. But as more and more the severe patients get severe and they get more symptomatic, there is something else that kicks in, and that's what we call as the alternative pathway, and there is emerging evidence for the last 11 years that I've been working here. We have been able to understand from different studies and sources that I've been involved with. So this essentially starts with the epithelium, where the epithelium can release alarmins, IL-22, IL-25, 33, and TSLP, that can activate these lymphoid cells. We call them the innate lymphoid cells that are like the lymphocytes but really are not lymphocytes. They stay in the airway. these can actually get activated by these alarmins because they have the receptors. On top of it, when you have too much of hemopoietic signal and the bone marrow makes a lot of CD34 eosinophil progenitors, they can get again recruited into the airway, just like eosinophils get into the airway. So when you have these CD34 eosinophil progenitors coming and getting stored in the airway, this homing is again through certain cytokines, T2 cytokines like IL-4, IL-13. And when you have these eosinophil progenitors right there in the airway, and you have all these T2 cytokines that are there, epithelial activation, your eosinophils might go away, but the innate lymphoid cells remain, and they can make so much of T2 cytokines. The progenitors can turn into mature eosinophils right there in the microenvironment. What I'm trying to say is, even if you don't have anything in the bone marrow, and even if you don't have anything in the blood, the airway becomes sustained, like the microenvironment has the cocktail to sustain eosinophil generation right there, and possibly why assessing the airway inflammation is so important. And we know that everything that I've put in red here, IL-5, IL-13, IL-33, TSLP, these are all drug targets right now. The different monoclonal antibodies that are there, these are all drug targets. So if we really look at the drug target, the first one was anti-IgE, which was to stop the allergic cascade. Thereafter, the anti-IL-5 neutralizing mAbs came out. So the mepolizumab and the reslizumab, which neutralizes the IL-5, as you saw in the previous one, that this was a key ligand. Then you have the anti-IL-5 receptor antibody, which will not only just block the IL-5 from binding to the IL-5 receptor, but also will cause any cell that has that anti-IL-5 receptor to be depleted. It really annihilates the cell by using this method called as antibody-dependent cytotoxic killing. So anything that has anti-IL-5 receptor, so it can be an eosinophil, it can be an eosinophil progenitor, it can be a innate lymphoid cell, it can be a TH2 helper cell, it can be a mast cell or a basophil. All of these will be killed off. Then you have the next generation of drug, which stops the blockade by blocking the IL-4 receptor IL-13 pathway. And the last one, the new kid on the block, is the anti-TSLP, which is the epithelial alarmin, and that's a neutralizing antibody again that will stop the TSLP from having its downstream effect. So we have number of drugs, and how are we doing in the adult space? I would say very moderate. If you look at the relative risk reductions in all the different major studies that have been shown, at best in the adult population, I think the situation is very similar in peds, if not a little bit more worrying. But it's almost like 50 to 60% of the times you're being able to reduce the exacerbation. But that means there's a certain number of patients who do not do well on these. So careful understanding of these trials and the ongoing literature would really help us clarify that the T2 burden that is in the airway is not reflected in the blood. And each one of these drugs and each one of these trials have selected patients based on the blood eosinophils, which I agree is a good marker of the TH2 burden. But as you can see, it is quite heterogeneous and complex, and it's not about what is reflected in the blood. There is much more there. There is something possibly beyond IL-5. The persistence of eosinophils may not be only T2. After a while, it could be maintained by other mechanisms. So it's very important to look at the airways, and the inflammation might be beyond eosinophilia. So there might be additional mechanisms, and that's the importance of bringing in biomarkers. It could be infections, it could be other immunodeficiencies, and many things. So that is where the importance of biomarkers lie. So let's look at what are the current biomarkers in use. The key one that we use is sputum, which is expectorated into a petri dish. Within the 2 hours, you can select the plugs under the microscope or on a opaque surface, and you process it. It's actually very simple. You disperse it in DTT and PBS, and you centrifuge it, and you can then extract the cell and the cell-free supernatant. The cells are put on a cytospin slide, and it's stained by a cytologist, counted, and the cell-free supernatant can be used for fluid phase mediators, which is more research, I understand, translational tools are not yet on the bedside. But the cytospin slide and doing the sputum and looking at the measurement has been done for almost more than 35 years here, and it's been done many places around the world. It can be used if you realize that it might be an important thing to do. And this is how a sputum cytospin slide looks. It's nice and clean. It does not have the red blood cells that you would see on a blood smear. This is that of a healthy individual. We have the cell counts, and the cutoffs has been established for almost 25 years now. So we know what is the cutoff, what is upper limit of control, and what will indicate airway inflammation. So here I would show you a cytospin slide of a patient who had intense eosinophilia. I would like you to show here that this is an eosinophil, this is an eosinophil that's degranulating. These are granule clusters. So this is a very symptomatic patient, and its cytospin slide literally shows, indicates that there is a high amount of eosinophilic activity going on, where the eosinophil is degranulating and releasing all these mediators, which would lead to the kind of symptoms that they're seeing. So putting these in numbers, when we look at the sputum differentials, if the total cell count is less than 10 million cells per gram of sputum selected, and the sputum eosinophils is greater than 3%, that is indicative of a T2 inflammation. There was 20% of patients have about no inflammation or POSI, as in no cellular inflammation. So these patients have normal cell count, does not have eosinophils greater than 3%. There is a very unique cell inflammation type, which is called the mixed type. It's getting more and more importance in the adult setting, where you have infections. There's recurrent infections. There's infection going in the background of having sputum eosinophils. So once you treat the neutrophilia, the infection with the antibiotics, that the eosinophilia often comes back. And then the neutrophilic inflammation, this is a very, very small subset, almost not, they're very, very small subset of asthma patients who have neutrophilic, pure neutrophilia, as in they have never had eosinophils even in the historical past, and infections are driving their asthma or their symptoms. It is also to be remembered that if the total cell count is in the normal range, and if you have neutrophils greater than 65%, that is what we call as trivial neutrophilia, and it is possibly due to a side effect of the inhaled corticosteroids, which may not, I don't think it has a clinical implication, and there has so far been no clinical implication of a trivial neutrophilia. It's only when neutrophilic inflammation is associated with a high total cell count, it's indicative of an infection. So does the compartments matter? So this was one of the first studies I did when I came here. So we took about 55 prednisone-dependent asthmatics, and I looked at their blood and the sputum eosinophils. And as you can see on this graph, you have sputum eosinophils on the y-axis, blood eosinophils on the x-axis, and there is absolutely no concordance of the counts, which means if the patient has a very high blood eosinophil count, the possibility is that they'll have sputum eosinophils. But if they have very high sputum eosinophil count, they may still have normalized blood eosinophils. And what I then did is I looked at all the other studies that had reported blood versus sputum eosinophil correlation, and I saw that the correlation is highly dependent on the severity of the cohort that the study was done in. So when the studies were done in mild cohort, and I've actually given you the studies here, and this is and this entire thing is in this publication in Lancet Respiratory. So when you have these studies in a cohort that are mild, there is a correlation between blood and sputum eosinophils. But as you get more and more severe, it becomes more of a lung localized inflammation, and that's very, very evident in this study. And it was a study a decade back, and we still see the same. And not just us, it's around the world that we are seeing that universally, though blood eosinophils are the surrogate markers for airway eosinophilia, it is associated with pure asthma control, risk of exacerbation, lung function. It does decrease with blood corticosteroid. But this study from Florence Schleich's group in Belgium clearly showed that if you have blood eos and sputum, like if you have sputum eos in these two conditions, that is what is associated with symptoms. So exacerbations or the ACQ, which is the symptom control for asthma. When you do not have sputum eosinophils, irrespective of whether you have blood eosinophils or you don't have blood eosinophils, you can see that the exacerbation rate is really low. So it's really, when you have the eosinophils tracking into the airway and the evidence of it, those are the patients who are actually symptomatic and have the risk of having exacerbation and need more clinical management. This, I think, is the best evidence showing it. Thereafter, recent data from the SARP cohort in US, where they're showing that it's not just the eosinophils, it's EPX. And the reason I'm showing this data and not our data, which was published in 2013, 2014, and again, another study of mine in 2020 that shows that the eosinophil activity, eosinophil peroxidase, which is one of the best activity marker for eosinophilic inflammation, that is more indicative of what is of the T2 burden than blood eosinophils. So in this study, and I'm literally showing another study because it's not our study to keep the bias out. It's done in about 479 asthma patients and over 3 years, and they show that irrespective, even if you have no blood eosinophils, so these patients would be considered to be having no eosinophilia, a good number of patients have a lot of sputum EPX, which means they are very like they have a lot of eosinophil activity in the airway, and possibly they are symptomatic. And this kind of increases with more and more blood eosinophil. So yes, agreed that blood eosinophil is a marker of TH2 burden, but having them below 300, so these two groups are below 300, you can see how many of them still have sputum eosinophils, and they have marker of sputum eosinophilic activity, which is EPX. So again, 20% of the patients have persistently high sputum EPX even over 3 years, irrespective of the treatment that they are on, and this is associated with severely decreased FEV1, polyps, and mucus plugging on CT. And sometimes the blood eosinophils using 300 cells per microliter may misclassify those who have a high airway eosinophilic activity, which is possibly contributing to their symptoms. Not possibly, which is contributing to their symptoms. The study also showed, this is a Sankey plot, which shows over 3 years that it's kind of fluid. But if you have had sputum high EPX, like, if you have had a lot of eosinophil activity in the airway, the chances of them having that very high activity in the airway remains 20% of them over 3 years, irrespective of the treatment that they are on, they may still remain so. So if you do not have this sputum eosinophils, what is another way that you can understand and assess airway inflammation? So the reason why I put this confusogram here is to show that FENO is not that simple a measure to say, oh, this indicates eosinophil activity or eosinophil inflammation. I wanted to just take this moment and again bring back my immunology background and 101 on what really is FENO, because I think in the peds population, this is becoming more and more relevant and important. How am I doing for time? Neeraj, how am I doing for time?
You have around 25 minutes or so.
Fantastic. Thank you so much. So on this confusogram, I want to show you that the FENO is actually a part of a constitutive mechanism in immunology. So you have a constitutive nitric oxide synthase gene and an inducible nitric oxidase synthase gene, so iNOS and cNOS. And the nitric oxide is released by the cells due to the increased activation of these genes, the NOS. So what essentially this nitric oxide does is it scavenges the cytotoxic reactive oxidative species, or the ROS, which is a homeostatic mechanism for reducing any inflammation. So any excessive inflammation that is happening in the airway, it can be because of allergens, it can be because of infections, it can be because of too much of pollution, particulate matter. So the airway is exposed to a massive surface, external surface. So there has to be these homeostatic mechanisms that can keep the inflammation down. So the NOS system actually is a way of scavenging out these reactive oxygen species, which can actually cause tissue damage. So this is just a way, it's a homeostatic mechanism. But when you have excess of nitric oxide, it indicates inflammation. And this excess of nitric oxide can be detected as FENO, what you can do at the clinic, what you can measure in the clinics. Now, the FENO, this nitric is essentially a marker of what is being generated, and the nitric oxide generating cells are many. So not just eosinophils, it could be the epithelium cells, inflammatory cells like mast cells, the lymphocytes, the B and the T cell, neutrophils. So not just eosinophils and basophils. It needs to be kept in mind that FeNO is a good marker of ongoing airway inflammation and not specific to eosinophil inflammation. And this is done by activating the STAT6 pathway, which is primarily by the T2 cytokine axis IL-4, IL-13, possibly why FeNO is used as a biomarker for identifying who would do well on dupilumab, which targets this inflammatory axis. So it is a non-invasive biomarker of airway inflammation that is being used, but it is not specific for allergic. So my apologies, that's not allergic. So it's a non-invasive biomarker for airway inflammation currently being used for assessing allergic and eosinophilic. But please be reminded that this essentially is a marker of airway inflammation. Early evidence of FeNO in uncontrolled asthma was again done in the Hargreave lab all those years back, where they showed that on an exacerbation, on repeated exacerbations, there can be drop in FEV1. Sputum eosinophil is definitely one of the markers that come up with exacerbation. Blood eosinophils, not so much, but FeNO did come up. So FeNO can be a marker of exacerbations and indicates airway inflammation. So we do have very early evidence data. Thereafter, there is the single-blind trial using inhaled corticosteroid therapy based, and they did this entire stratification where they used guidelines to give the treatment and FeNO to give the treatment. And they saw that the reduction in the exacerbation was really like assessing it via FeNO, there was no significant difference. So it's possibly because the corticosteroids, the reduction in eosinophil is the best marker for response to corticosteroid. FeNO can be from a number of other sources, not really eosinophil. So possibly why this study did not reach significance. However, from Professor Pavard and Dr. Couillard, who's a colleague and a friend of mine here from Canada, we have come up with this scale of having high FeNO and high blood eosinophil. So I would really ask you to look at this study that is recently published in the Lancet or Oracle 2, and I have kind of given this data above the previous one, is to show that if you have blood eosinophils and FeNO both raised, these are patients that have maximum risk, have the highest risk for exacerbations, which kind of means that you have now two things that's confirming a burden of airway inflammation in the airway. And these can be very well be used to identify patients who are at risk and needs careful clinical management and possible targeted therapy beyond corticosteroids. This is another study, a huge study done with about more than 3,000 patients, led by Professor Celeste Post-Buck. And why I've put this graph in is because you can see that based on FeNO, and on the y-axis you have the probability of uncontrolled asthma, you have lung function decline, you have exacerbation. Based on FeNO, there is absolutely no difference on whether you use IgE IL-5 receptor or targeting the IL-5 pathway or targeting the IL-4 receptor pathway. If you really, really look at the decrease in exacerbation, annual exacerbation rate, or improvement in FEV1, there's no difference, which means any one of these drugs can actually help anybody in that manner who has low or high FeNO, which means it's not just one biomarker that's helping. It's possibly the combination of biomarkers, or possibly adding symptoms to it or history to it. So as a clinician, you'll have to keep that into mind. As an immunologist, I'm just giving it clearly to you that FeNO is a very heterogeneous marker of holistic airway inflammation, and possibly why that's what you're seeing in the outcomes and in the clinical outcomes. However, if we look at the exacerbation rate, and when they did regression analysis using anti-IL-4 receptor alpha, so using dupilumab, there was at least a significance showing that this is possibly the only one that will show or predict a reduction in exacerbation. And this is possibly because IL-4, IL-13 is involved in the release of FeNO, and possibly this is also going to reduce patients who have mucus. So when you see mucus in their CTs, or when you see mucus in their bronchs, and you see there when you're doing their bronchs and you can see a lot of mucus plugging, these patients might have an increased IL-4 IL-13 pathway, and they may actually have very high FeNO. So they might be very indicative of they might be the population that might be projected to benefit most from DUPI. That said, we did a quick study to assess this whole residual inflammation on FeNO, and we did this again in an adult population where we took patients who were on anti-IL-5, and both the anti-IL-5, so the neutralizing ones, mepolizumab, racilizumab, and the benralizumab one, and we saw that really FeNO does not get reduced. So irrespective of the treatment response, irrespective of whether eosinophils were reduced, because we know that benralizumab depletes sputum eosinophils. With mepolizumab and racilizumab, there is a reduction in sputum eosinophils. Mepolizumab, some patients still may have eosinophils, but with benra, we know it completely depletes eosinophils. This is another paper that I published last year in the American Journal, in the Blue Journal, where I showed that FeNO can still be there irrespective of depletion of sputum and blood eosinophils. So which means that the IL-5 treatment is not reducing FeNO, because of course it is not part of that mechanism. And using the system, using the cytokines, you can further assess what is leading or what is keeping the airway inflammation on. And here what we did was pre and post treatment, we looked at 2 parameters. So this is something, again, you can possibly take it back to your clinics because you have FeNO in the peds population. Look at whether they have a raised FeNO, or between treatment or post treatment, if you want to assess their whether they're doing well on a treatment, assess if they have had a change in FeNO by 16 parts per billion, which is like a MCID for FeNO. And based on that, you can assess that whether at all the treatment is reducing the inflammation. So here you can see that despite reduction, whether they are raised or normalized, they can still have certain cytokines, and very individualistic in different patients. In general, the IL-4 and the IL-13 were increased, where the levels were higher in patients who had raised FeNO irrespective of the anti-IL-5 treatment. We also looked at other cytokines, and indeed, this is really interesting because you can see cytokines associated with the inflammasome pathway, which is a non-T2 pathway, still being raised in those patients. Again, even in both the groups, whether it was in some patients who had normalized their FeNO, and some patients who still had raised FeNO. So what I'm saying is that this is not always about T2 inflammation. So FeNO can be a marker of airway inflammation, and inflammation that is being driven by other cytokines or other inflammatory pathways, which are not the general T2 that we know. So then that's why we come to the point is reasons why there might be a failure of surrogate endpoints in our trials, and if we don't think about trials, at least in your patients. So think about this, that you have the disease and you want a true clinical outcome. So in this case, if the disease affects the putative surrogate endpoint and the true clinical outcome via different mechanisms, so you cannot really correlate between the biomarker and the endpoint because the two are not causal. It might just be an association. And this example I can give you is of serum IgE for predicting response to omalizumab in severe eosinophilic asthma. So if you have serum IgE, the patients who have allergic asthma, they do best, right? But if it is a severe eosinophilic asthma, these patients might be non-atopic. So they may not do well on IgE. So just to show this, I'm just plugging this thing. Okay. So when it comes to Xolair or omalizumab, the total IgE is measured in the serum, and also allergic specific IgE is measured as well. So we know that the guidelines say that if the IgE is high, you give them Xolair. Okay, this has worked beautifully for more than a decade in managing patients with high IgE asthma and those who have allergies. But targeting IgE depletion does reduce exacerbation of asthma by 25%, but especially it gets worse. Like this whole thing, it doesn't do very well as the asthma severity progresses, irrespective of whether they have eosinophils or not. So this is a study that I did a while back, again in my postdoctoral role, where we saw that if patients have airway eosinophilia, there is the omalizumab does not reduce sputum eosinophils. And thereafter, Professor Ken Chapman from UFT, just down the road, did this study of switch. And based on which we wrote an editorial. I wrote an editorial in Allergy where we talked about this study, and we basically said that those patients who remained uncontrolled, had exacerbations on omalizumab, when they switched them to mepolizumab, there was a significant reduction. There was a number of patients who didn't do well on mepolizumab, on omalizumab, did very, very well on mepolizumab. But that was not all patients. It was 77% only. So there was a subset of patients who did not do well even on mepolizumab despite having eosinophilic exacerbations, right? So this is very important because here the blood eosinophil is only in relation, and it's not completely causal with the outcome that you're looking at. And same with the IgE. IgE is only associated, it's not directly causal to the outcome of a severe asthma patient, because there are many other things that's driving the severity or the symptom or the pathology. The second scenario B, which I'll bring in, is where your intervention itself affects the putative surrogate endpoint. It reduces it. So which will have some impact on the true clinical outcome, but several other mechanisms are there which makes this biomarker an unreliable measure of change in the true sense of the clinical outcome. Example is blood eosinophils as a biomarker for guiding biologic treatment. So we have been having this discussion as I've been showing you my slides. So this is literally where it becomes very obvious. Let's show you the study that we did. We took about 250 patients from 4 academic centers across Canada, and these were patients who were clinically prescribed. So this was a real-world setting where they were clinically prescribed an anti-IL-5 neutralizing antibody, which means they were best suited for it. They were patients who had high TH2 burden blood eosinophils. And out of that, 43% showed suboptimal response to therapy, 14% showed worsening of symptoms. And the suboptimal response was greatest in patients who were most severe. That means they required prednisone. So when we look at these patients, so this is a graph that I've taken end of the study, so after treatment, so many of them still had sputum eosinophils, and you can see it is mostly by the red dots, which are the non-responders. So when you divide the quadrants, you will see most of the suboptimal responders, SRs, are in the quadrant where blood eosinophils are normalized, but sputum eosinophils remain, which means it's the eosinophils in the airway that is driving their symptoms and causing a reduced response to a treatment that should have otherwise worked on theory. This was again showed, I am again bringing in this slide because the same study, this study that I showed about 10 slides back, the SARP study, many of these patients, 53% of these patients were on mepolizumab. And again, irrespective of the anti-IL-5, if the sputum EPX remained high, so which means mepolizumab was not being able to get sputum eosinophils and their activities down. And this might be again because of the fluidity that remains. So just because it's eosinophilia in the airway doesn't mean that it is being driven by IL-5. That's where the concept of endotypes come up. So here is a UBioPred study, which is a biomarker-based large cohort that is done across Europe for finding predictive biomarkers. This is one of the studies that was published 4 years back, where they showed that doing the transcriptomics, you can understand that even if you had eosinophilia according to the sputum differentials, or had a mixed sputum differential, or was neutrophilic or PASI, these 3 clusters that they had were based on the gene expression. So if within the eosinophilic patients, you had 2 things that were driving eosinophilia. It could be TAC1, it could be something to do with CCR3, which is the eotaxin eosinophilia. It could be the epithelial activation that was leading possibly the innate lymphoid channel, bringing in the eosinophils. It could be TAC2, which might be something to do with tumor necrosis factor, inflammasomes, because we do see that signature. And of course, there are other factors that are there, maybe in the mixed one, which might be bringing the metabolic pathways, mitochondrial function, etc. Further on, what they have also done that in later studies, they have shown that this fluidity is not at one time point cross-sectional. It can be at number of time points. When you have follow-up patients, just because the patient was eosinophilic or maybe had an IL-5 driven eosinophilia does not mean the same will happen at year 2 or year 3 or your second or third follow-up. So the fluidity of airway inflammation needs to be remembered, which means you have to do an assessment every time you see a follow-up, or every time there's an exacerbation, or every time there is a assessment of whether this patient is going to exacerbate. And this is why understanding better endotyping, like the biomarkers to better endotype the patients, is required for making better judgment calls with using these expensive biologics. And in the last few last few slides, I'll show a few examples of biomarkers that are in development. So as remember, I talked about the eosinophil peroxidase. This is one of the seminal papers that came out of late Professor Jamie Lee and Perham's lab, where we showed that very high level of EPX, eosinophil peroxidase, is indicative of eosinophil activity in the airway. And following this work for the last decade, we have been working on developing point-of-care tests in sputum, so to measure not just EPX, but also myeloperoxidase, which is a marker of neutrophilic or infective exacerbation, and tryptase, which is a marker of mast cell activation. So this would be almost like your lateral flow test, like your pregnancy test. So you add the sputum to it, and you should be able to see a line which lights up, and that will give you an assessment. So that's what we are developing. You can also look for Charcot-Leyden crystals in the sputum smears. More than often you can see them, and that's an indication of a very severe airway inflammation, eosinophilic, because Charcot-Leyden crystals are absolutely specific for eosinophils, galectin 10. So, and those patients are more than often IL-4, IL-13 driven. Periostin, again, is a marker for IL-4, IL-13. It's under development. Volatile compounds are under development. This might have a big market in the pediatrics because it's the ease of just breathing into a machine. There is a sputum 6 gene signature. So this is something that Dr. Gibson down in Australia is trying to work on, looking at this the gene signature that can assess whether there's a neutrophilic or a eosinophilic exacerbation. This is a beautiful paper. I would ask you to please have a nice read. It's a really nice paper. And of course, there's something that I am developing to look at directly at the cytokines that's responsible, possibly what is there in the airway, and which cytokine and which marker might be useful for understanding the treatment and the response to treatment. So coming back into the summary of the biomarker landscape that I started this talk with. So when it comes to diagnostic biomarker, yes, serum Ig is a great example. It is good for diagnosing atopic allergic asthma. Blood eosinophils, great for diagnosing if it's an eosinophilic asthma with a high TH2 burden. And sputum eosinophil till today remains one of the best surrogate markers for assessing airway inflammation and confirming if it's a true eosinophilic inflammation in the airway. You have monitoring biomarkers. Again, we have been using sputum for titrating corticosteroid doses, and also a number of studies that's confirming right now that it is one of the best markers for biologic response, not just from our group, but also from Belgium, also from Copenhagen, also from England, also from Australia. There are response biomarkers. So one, blood eosinophils is being used, and I've shown you data that it is not a good response or a therapeutic biomarker at all. Predictive biomarker, FENO is being used as a predictive biomarker for those who might do well on the dupilumab, because it's the anti-IL-4, IL-13 that really drives FENO. But there are other inflammatory signaling pathway that can also increase FENO, because FENO is a very holistic biomarker for airway inflammation. And prognostic biomarker, this is a specific biomarker for specific clinical outcomes. So it's a huge area for understanding biomarkers and how we can truly use it to help our patient population. So the unmet needs are to find biomarkers beyond eosinophilia for other treatable traits, for example, mucus plugging. In Canada, I'm leading a team grant across 6 to 7 sites across Canada that will look into mucus plugging in severe asthma, COPD, and chronic cough. And we do have a pediatric population, which is being led by Dr. Zeman C and myself, where we will be looking at how mucus plugging and the airway inflammation in those very difficult to treat children who have a lot of wheezing and infections. There is a need for understanding prognostic biomarker to understand how the disease may actually progress from mild to moderate to severe, which are the patients who run the risk of having severe asthma. Predictive biomarker for identifying the right patient for the right drug for the right outcome. Number of biologics there. So I think it's a great time in complex airways disease to really understand what we can do with these biologics that we have. They're great drugs, they work, but we just have to make sure we give it to the right patient. We do need monitoring biomarkers to really assess when we can make the switch if by chance that drug is not working and who might actually do well on it. And this understanding the potential of current biomarkers in other airway diseases like COPD, which is not a PEDS issue, but of course you can think about other patients who have recurrent exacerbations. And of course, like I said, there's a huge gap. So I hope I'm going to leave it here and we can have a nice discussion. I'm really looking forward to it and getting your clinical insight into it. I will leave with this thought process, and which has really guided my research program thus far, is the need to look into the roots. So this is my homage to my favorite philosopher from the 13th century, Rumi. Maybe you're searching among the branches for what only appears in the roots. That's the need to look into the airways. Thank you.
Manali, I think wonderful means like I do not have any particular word or any particular sentence to praise the talk. And this I am saying because I myself is presenting so many talks on airway inflammation and biomarkers, and we have heard so many speakers. But like the way you have taken the things from the starting and then you have tried to explain the things in such a beautiful manner that we understand that we just probably know only a pinch or probably less than that of the entire sea or whatsoever. So I would like to now put you a very simple question. Like I'm a clinician. So
Yes.
till now, what I used to do, and after hearing your talk, now I want to modify. So till now, what I used to do is that, like for an example, if a child comes to me in my clinic, and I feel that okay, this particular child seems to be having asthma with all those criterias and everything, and now we understand that in pediatric age group, usually it is the TH2 inflammation which predominates, right? So what I used to do that as per the age and the feasibility of the child, I usually do a pulmonary function test. And if there are certain nasal problems, then I usually do nasal FENO. And
Very good.
rather than doing the bronchial FENO, I usually do only the pulmonary function test. And if there is a reversible airflow obstruction, along with nasal FENO, and if only one of them is deranged or both are deranged, depending upon that, I deduce that okay, which particular part is more inflamed or you can say like both are inflamed, and I try to treat them. Suppose if they both are means like getting better, then that is fine. I am not repeating any biomarker. I'm not doing anything. But suppose at any particular point, I feel now there is a problem. Then at that particular time, I usually conduct, you can say like certain tests could be repeat FENO or certain other biomarkers which I would be looking for, and then simultaneously allergy testing also. Now, after looking at your talk, my few questions to you. How should I change my approach in the sense, for an example, to start with, should I start looking for bronchial FENO, nasal FENO both? One. Second, the other thing is that, for an example, in follow-up, suppose if the FENO levels are reducing, or then at that particular time, whether it is the response to the steroid which is happening, or whether it is the asthma is now changing from the eosinophilic to the neutrophilic asthma, means like how should we take one particular example, one particular case, and at one particular time, which biomarker we should do, and then we should repeat and we interpret. Just in a flowchart type of the thing. I'm just asking you to summarize your talk in a flowchart.
Okay, so again, disclaimer, I'm not a physician, but I'm going to give you from the translational immunologist perspective how I would use science to deduce this algorithm, and also given what I know from the adult population. So the first thing that I would look at is blood eosinophils. Is there a TH2 burden, right? With that, you're looking at FENO. Now, if you have, so say I'm starting with nasal FENO. So you have nasal FENO, you have blood eosinophil. The highest likelihood the patient is eosinophilic, or the symptoms that's being driven is eosinophilia. Now you give them a therapeutic intervention. The blood eosinophils is the first thing that will respond to the treatment, whether it's whether it's corticosteroid or whether it's, I don't know, I think mepolizumab, Nucala is available in India, right? So,
Yeah.
so you will see depletion of blood eosinophils. Now, what you'll see is nasal, whether the nasal FeNO is getting down or not. I think it is at that moment when you have to, because when you're bringing the patient back in is only because they are symptomatic and you're assessing whether the treatment you're giving is right or wrong. That's when I think you have to introduce the bronchial FeNO bit. Because yes, nose, I mean, I hate to say this, but Professor Robert Schlemmer used to always say that the nose is the part of the lung that is accessible to the finger. But it is after all the lungs that we're looking at, which is deep and seated. There are so many generations. There is the central airway, there's the proximal airway. You don't know where the issue is. And of course, it's a child, so you cannot expose the child to CT or bronch unless absolutely necessary and indicated. So you can't go there. So what I would suggest is, since bronchial FeNO is non-invasive, it makes sense to let them have that. What needs to be remembered is, if there has been an infection, if the child had an infection, that might also increase the FeNO, right? So you have to make sure that there was no other issues that could have caused an increase in symptoms or a flare up. So if there has been no infections, nothing, then you looked at the bronchial FeNO, and the bronchial FeNO says high. I can make a very good educated guess that there will be a number of times when your bronchial FeNO might be high when your nasal FeNO is not. So in a good subset of people, you would possibly be able to right away figure out that, yeah, there is still airway inflammation irrespective of what the blood eos go down. So then you can, if there is bronchial FeNO that is high, and the blood eosinophils have gone down, and the patient is still on, say, steroids and Nucala, the chances it's not an IL-5 driven process. So it could be a T2 driven process. Now, what you have in hand is, what are the drugs that are available to you for peds? Do you have Fasenra there or Dupixent?
No, we don't have.
So you don't have. So the thing is that, when you don't have, then it's a possibility is that either it's a wholesome T2 burden, much bigger, which is just not IL-5, and possibly there are other cells that are involved, not just eosinophils, which needs to be taken care of. And the Nucala at its 100 milligram subcutaneous is a low dose, fixed dose, which is possibly not enough. I think as a physician, you have to assess whether you want to keep the patient on Nucala, possibly bring that patient more regularly in and assess lung function. If the lung function declines, or if the FeNO still remains high, or they're getting more symptomatic, I think it makes more sense to stop the Nucala at that time and titrate the corticosteroid doses, and possibly go into bronch and check if there might be mucus that is driving this. So right now, for adult patients, we would give them dupilumab. We will be assessing their sputum in the airways, and we will see if there is eosinophils, and we would give them benralizumab to reduce TH2. If it is not benralizumab, if it is more FeNO and mucus, we would give them Dupi, because that is what makes based on scientific evidence, scientific sense. But when you do not have that, then the chances are that it is something else, pan-inflammatory, now beyond IL-5, that is driving it, and that you might actually have to resort to corticosteroid titration, and having bronchial FeNO as a monitoring technique of that. This is just something anecdotal that I'm trying to say, but this is what needs to be assessed. Hopefully, from our trial that will possibly in 2 years' time, we would possibly have the data in peds population, that especially those children that are very symptomatic, wheezing, gets infections, and they're indicated for CT or bronch. We'll be able to try and see what might be the general inflammation that we get. We'll maybe be able to understand population better. And it actually has a great space in at your end to do some even clinical studies. It doesn't have to have very hardcore scientific research, very hardcore bench research. You can do the scientific research just using clinical outcomes by just assessing it. Because I think if the patient is not doing well, then taking them off Nucala makes sense, because IL-5 might not be driving the issue and you might just be causing more harm without knowing it.
Yeah, I understand that what you're saying. Just two, three more brief observations or questions to you. One, like as you rightly mentioned about the blood eosinophils, but in this part of the world, actually means like the parasitic infestations and the worms. So this plays another role. So I'm not sure that how much the blood eosinophil values will be, you can say like practically we can use in each and every case. So that is why in our practice, we are not usually doing blood eosinophil levels using.
Because
So
the tropical nature. But do you not have a way of um, eradicating, like, evaluating it and just seeing that whether, like we do, we evaluate for parasitic infections, and if it is not there, we reject that as a reason. But I believe what you're trying to say is it is almost evidently always a reason.
yes, so that is why we are not doing actually blood eosinophil levels in majority of the cases. So this is one. The second thing is that many a times you will agree with me that many a times like these FENO values, the cutoff values which have been given like 25, 50 or 20 or something like that. So these cannot be taken very sacrosanct. Reason behind, because suppose for an example, if in a given case of asthma, which is probably associated with rhinitis, and now if you are doing a bronchial FENO alone, and you are getting a value of let's say 55, 60. Now this is positive, we understand, and we are not doing nasal FENO. But if we are also doing nasal FENO and the nasal FENO is coming somewhere 600, 700, so it might be possible that this particular nasal FENO itself is responsible for a little high or a little positive or borderline positive your bronchial FENO. So is it possible or not possible?
So it essentially means there is eosinophils in the lung. It essentially means there is eosinophil in the lung. So if I have to logically put this in place, it is also the physical environment and how much nasal filo in a small little area, considering the lung, which is 400 square meters square of area that's been packed into a small. So I would not reject bronchial FeNO at 50 parts per billion or 60 parts per billion for a child at all, thinking that it's coming from the nose.
Can't it come through the posterior side of the nose? No, means like nasal FeNO somewhere around 600, 700. And can't it come a little bit contribution to the posterior side of the nose and coming to the oropharynx and diluting it? Even if
But do they have wheezing?
no,
Are
even
there
if,
symptoms?
what I'm saying is if a patient who is coming to us with coughing, and now we don't know whether this particular coughing is because of the nose or because of the chest.
Nasal drip or, yeah, okay.
And
So
at that particular time, if we are doing a PFT, the PFT is absolutely okay, including oscillometry. And our bronchial FeNO is coming out to be somewhere around 55, 60. Nasal FeNO is somewhere 600. Then at that time, I usually feel that probably it is because of the trickling from the nose, which is actually giving it like a borderline positive. And usually I treat them only with the inhaled nasal steroid without giving them an inhaled corticosteroid. So this is
So this
my
is making, okay, I see, this is a very interesting point you point out. This is making me think is that I think you'll have to understand if the patient is on corticosteroids, or a Nucala, a more targeted one and a high dose corticosteroid, then I believe 50, 60 is not borderline, it's high. 25 will be borderline then.
Yeah, but majority of our pediatric patients are not on Nucala, not on any high dose steroids, majority of the time. On the contrary, because we are allergists, so what we usually do is that we try to find out the allergen and we try to institute other measures simultaneously, like avoidance or immunotherapy. So usually means like our patients are not requiring, or at least majority of the patients are not requiring higher dose steroids or mepolizumab or something like that. If we are taking care of comorbidities, we are taking care of allergens, we are taking care of other things in total. So actually, in the pediatric age group, at least, they are actually not requiring that much as compared to that as well.
Yeah, I hear you, but I still would not reject out the bronchial FeNO if it's very high.
Okay, right.
I would not, because after all, the sampling, when you are doing the FeNO from the mouth, the air comes really from here. The physiological, if you look at the physiology of it or the physics of it, it's coming from, you're blowing in, whereas nose, you're blowing out. Yes, there possibly is a trickling of maybe the nasal bit, but it would still be indicative And more than often, if there is that high inflammation in the nose, there is possible inflammation in the upper respiratory. I mean, that's what I have at least seen in the adult population, but the peds are very different. But this might be a study that you can do. It sounds so cool. It can actually be a study that you can do to see that whether these patients would do better on an inhaled corticosteroid or just on the nasal steroid. Maybe this is a good clinical question to ask. I would be interested to know the answer.
My last question to you is about the sputum eosinophils. Majority of the time in pediatric age group, we are unable to find sputum from the child. Then at that particular time, if possible, I am understanding that the bronchoscopy is definitely invasive, but suppose if possible, bronchoalveolar lavage, is BAL a representative sample of sputum? Or means like whatsoever information we are getting from sputum, is it the same information from BAL or no? Because it is getting the sample from a different area, not from the exact sputum.
This is always asked. Okay, there has been no head-to-head study between sputum and BAL, but through my personal communication with Professor James Chalmers in Scotland, Dundee, just this summer, because we both work on this topic, and he works in bronchiectasis, I work in asthma, COPD, and indeed there is a nice correlation between BAL and sputum when it comes to inflammation and inflammatory cells, and even transcriptomics. But essentially, on theory, on paper, bronchoalveolar lavage collects or is representative of the segment from where the lavage is drawn out. For example, the macrophages will mostly be alveolar, whereas the sputum is mostly from, the induced sputum would come mostly from the 5th or 6th generation. It's mostly central, but more than often, it is one of the best indicators of airway inflammation. And both are indicators of airway inflammation. If you ask me about cytokines, then yes, the values might differ, because one is sampling from many compartmental areas compared to sputum, which is sampling from the first 6 generations. So maybe the sputum cytokines may differ, but even then, both are, I think, quite representative, at least in the case of asthma. COPD changes because there is the alveoli really comes into play. So if it is, we are looking in asthma and not a distal peripheral disease, then I think it can be representative of the airway inflammation.
Great, Manali. Thank you so much. And I think we have gained a lot. And we understand that there are so many other things which we need to really discuss with people like you. And we would love to have you again and again to have more interactions, to have more understanding about the disease. And we can probably move towards precision medicine by understanding these molecular mechanics more. And we can provide better care to our patients. But thank you very much. Thank you for joining us today. Thank you. Thank you.
Thank you so much for the invitation. It is always a pleasure speaking.